Thank you for the invitation. It is a very interesting topic. So this is the structure of my talk. I'm going to the next 15 minutes to all these issues. In order to give a main message, we have to be aware about insomnia in patients with respiratory diseases with or without obstructive sleep apnea. You all know that almost 1 billion people over the world have sleep apnea, and also 10% of people have chronic insomnia. These entities are very common, and even if there was not a single common pathway connecting them, it would be very possible, even by chance, for these entities to coexist. Now, we know that 30 to 40% of people with insomnia have sleep apnea, and also 30 to 50% with sleep apnea report insomnia symptoms. This is not something new. This is a knowledge from almost 30 years, although there was a silence, an absence of research for almost 30 years. The first report was by Christian Guilleminot in 1973. As you can see in the figure, after 2010-2015, there was an increasing research in the field, which is now a very interesting and common topic in sleep medicine. But we have to start from the beginning. The first report of insomnia in patients with sleep apnea was from Christian Guilleminot, 1973, in 2 patients with sleep maintenance insomnia and early morning awakenings. Both patients had a full PSG at the Stanford Sleep Disorders Clinic, and they found to have sleep apnea. But 2 patients may be a low number. But the next study, 3 years after that, had 56 patients with full PSG. 56 patients with insomnia. This is a good number, especially now when PSG are not performed. So they found that almost 11% of these patients had obstructive sleep apnea. And the main message is that we should not give without caution benzos, namely medications that may exacerbate the manifestations of OSA in patients with insomnia. Every time we have the suspicion for an underlying sleep disorder, as OSA, we have to be very aware about the medication we are going to give. So why is this 30 years gap in research? Because simply in the mind of physicians, and also sleep physicians, sleep apnea is connected with sleepiness, and insomnia is something else. So this entity doesn't come together in the mind. If you can go back 20 years ago when we give the sleep words, the main one of the most important question is what was a contraindication for a PSG? And the answer was insomnia. The only way that someone could reimburse from the insurance company the cost of a sleep study in patients with insomnia is if there was an underlying sleep disorder like sleep apnea, like parasomnia, like neurological disorders such as epilepsy, or restless leg syndromes and periodic leg movements. This is a slide you all know, but the question is not if a patient with low or high apnea and hypopnea index may sleepy or non-sleepy. The next question we will have in the next years is to have creative ideas like how many of these patients with mild, moderate, severe obstructive sleep apnea based on EHI, sleepy or non-sleepy, have comorbid insomnia during sleep. And you know that patients actually underreport their sleep problems to general physicians because they are the start. First, the patient is going to a general physician, a pathologist, and then he's going to the sleep physician. So all people have to be aware about that. And we know that chronic insomnia affects almost 10% of the population, even though there is another form, the transient insomnia, that affects almost 30 to 35% of the population. So it's time for awareness. Insomnia is not only the inability to sleep. Insomnia refers also to sleep maintaining problems, or in cases of patients who are waking up in the early morning and they cannot go back to sleep. Most patients with respiratory diseases, with or without sleep apnea, have sleep maintenance insomnia. In order to use the term chronic insomnia, the patient should have something during the day, a problem. It can be fatigue, it can be memory issues, mood issues, impaired social and occupational activity, and all the things you see on the slide. And also, in order to call the term chronic insomnia, we have presentation of insomnia at least 3 times every week and for a duration for at least 3 months. The thing we know about typical chronic insomnia, pathophysiologic insomnia, is that the patient is not sleeping during the night, even though if he has the opportunity to sleep during the day, this is not possible because of the running mind. So people with chronic insomnia usually are not sleepy during the day. On the other hand, people who have chronic insomnia as a result of respiratory diseases or COMISA, comorbid insomnia and sleep apnea, may be sleepy during the day. And this is a very important key point to recognize this patient. This is a very important graph. You can go through this paper. It's very interesting to read. But I'm going to clinical practice. This is a patient with COPD. You see the X-ray, you see the characteristic flow volume loop. This is a full night PSG, and you see that we have REM-related obstructive sleep apnea as well as hypoventilation during REM sleep. The main problem of this patient was sleep maintenance insomnia. And it's obvious that cough, for example, may be a reason for difficulty initiating sleep, and this can be treated by medications. But as I told you before, the most important thing is that the patient may wake up during the sleep, especially during REM sleep, as a result of hypoventilation, hypoxemia, or obstructive sleep apnea. And this may be the beginning. An organic cause is waking the patient in the middle of the night, and then the running mind doesn't allow the patient to go back to sleep. Insomnia is related with almost medical disorders, not only pulmonary disorders, cardiac disorders, as well as neurologic disorders. We have to remember that many patients are on medications, and medication can also cause insomnia. But remember, the main thing is depression and anxiety, namely psychiatric disorders. And patients with respiratory disorders, even restrictive or obstructive, are often depressed and anxious. And don't only point on obstructive sleep apnea. There are also circadian rhythmic disorders and also restless leg syndrome and periodic leg movements during sleep that may disturb sleep and produce insomnia. The most research in sleep and respiratory disease is or at least was in COPD. So insomnia is common in COPD, as you can see in this graph, and also COPD patients may be sleepy during the day. Smoking is a factor that increases insomnia during the night, all kinds of insomnia, as well as coexistence of depression or anxiety. On the other hand, medications available for COPD and oxygen use may provide better sleep with no insomnia. This is an older slide. It concludes many diseases, almost all kinds of obstructive diseases, asthma, chronic bronchitis, emphysema. That was the way we saw these COPD issues in the past. The main thing you have to point here is that these patients have sleep onset and maintenance insomnia, and they may also have excessive daytime sleepiness. In patients with idiopathic pulmonary fibrosis, namely the main restrictive disorder of the lung, may also have sleep issues. They may not be able to sleep as a result of multiple awakenings, and the main cause of that is cough. And after that, it's dyspnea. This was a study we performed with Dr. Schiza many years ago in patients with IPF, and we have a great research in this field. So these are the hypnograms from patients with IPF with or without obstructive sleep apnea. And as you can see by the arrows, there are all the all the types of insomnia: sleep onset, sleep maintenance insomnia, early morning awakenings. But things are very important also in asthma patients. Asthma patients may wake in the middle of the night, and this may be a result of the circadian changes in the hormone levels related to cortisol, epinephrine. And this is something we have to point every time we give treatment for this patient, because we have to cover the nighttime symptoms. But in cases of refractory asthma patients related to the treatment, the given treatment, we have to think that this patient may also have obstructive sleep apnea. In these cases, it's very common. It's 3 to 3.5 times more frequent to have obstructive sleep apnea. And if we treat obstructive sleep apnea, then we can treat the disease by itself. In real world, we don't have only one disease. We have multiple diseases. So one patient may have hypertension, diabetes, COPD, asthma, arthritis. And the more problems we have in the same basket, the more possible it is to have insomnia, and even more severe insomnia. And this is the real world. In patients with interstitial lung disease, the phenotype recognized for many years is the fact that this patient have all kinds of insomnia. They have daytime sleepiness, but this is not the most common feature. It's more common to feel fatigue and mood disturbance during the day. Those are the 100 phases of COMISA. And not to forget the last one, the restless leg syndrome and periodic leg movements during sleep, especially in patients with COPD, as well as in patients with IPF, in 2 studies that show that this may be the reason that disturbs the sleep and initiates the running mind of chronic insomnia. So what is the diagnostic approach? The diagnostic approach is clear. The rules are so clear. These are complicated patients. In patients with cardiopulmonary disease or insomnia, who have to perform a type 1 formal in-lab PSG. These are the rules. And where in a facility, in a sleep facility, and under the supervision of a board-certified sleep physician. Otherwise, we are going to lose time and money. And don't believe that with home studies, we earn money. It's better to go with the right way and not disturb the whole procedure. And if we are talking about money, only insomnia has a cost of billions, not millions, billions. The same thing exists for obstructive sleep apnea. So we cannot deny a sleep study in a complicated patient in order to find a solution. So every time we have insomnia, and insomnia is not treated with CBTI or the other medical treatments we have to suspect that something else is happening during the sleep. So in this time, this complicated patient may have a full night PSG. Is COMISA related to cardiovascular events? Yes, the sleep heart health study, one of the most important studies performed in the past, and these are data from this study, showed that patients with COMISA may have increased incidence of cardiovascular events. And this is one study that can talk with apnea-hypopnea index. In order to use the term apnea and hypopnea index, we have to use the electroencephalography. And this was a type 2 study, home study, even though much better compared to the studies performed right now, because they had full EEG. And having this, they can recognize hypopneas because hypopneas should have a desaturation of more than 3% and or arousal. In order to recognize cortical arousal, we need EEG. Otherwise, we cannot use the term apnea and hypopnea index, EHI. 2% of these almost 6,000 patients had COMISA, and it found that survival probability was significantly impaired in patients with COMISA as a result of cardiovascular events. The same things were prescribed in the Wisconsin sleep cohort study, where comorbid insomnia symptoms and sleep apnea are at increased risk of all-cause mortality. And this is a newer study, very important, because there are 3 things that are important in cardiovascular morbidity and mortality: short sleep time, insomnia, and obstructive sleep apnea. These 3 together. Short sleep time is the new factor we have to take always into account. And we are going probably to discuss the next year about diabetes. It's obvious that diabetes, metabolic syndrome, and all these metabolic abnormalities in OSA are more common and can produce more negative effects in case the patients have also insomnia phenotype. So in order to treat COMISA, or in order to treat insomnia and respiratory diseases, we have to treat, first of all, the main disease. We have medication, we have oxygen. So irrespective if it's statistically significant or not, all studies show that medication and oxygen improves sleep in patients with COPD. In patients with obstructive sleep apnea, the initiation of a CPAP device is improving significantly the quality of sleep. And somebody can say, man, I don't sleep without nothing. And if you are going to put me on a device, a mask on my face, am I going to sleep better? Yes. If the device is put the device we really need in after a full diagnosis is very, very important, because if everything is done well, then we can have a better sleep. If somebody tries without diagnosis, with home portable studies, to initiate devices like ESV, adaptive servoventilation, BiPAP, in patients who are not need these devices, then they may produce more insomnia compared to the past. So we have to find insomnia, we have to find obstructive sleep apnea. In a well-organized sleep lab, we know all these methods, and we have to go to medication, to CBTI, to PAP therapy, to oral appliance therapy. There are many medications we can use for insomnia. These are not only the Z drugs or the benzos. These are medications that are antidepressants, anti-epileptic drugs, or antipsychotic drugs. In order to use this medication in a patient with no anxiety or no depression, we use the medication in very low dose in order to have a positive side effect. And this positive side effect is to make them sleepy and to make them go to sleep. But someone has to use the medication if he is real sleep physician and if he knows the pathophysiology and the mechanisms of all this medication in order to produce a good result to the patient and not harm. Related to Z drugs, especially ezopiclone, is related to a better sleep. It does not increase the apnea and hypopnea index. It does not worsen obstructive sleep apnea. Only for zolpidem there are some negative reports, even though this medication, the Z drugs, are safe in the hands of a sleep physician in order to try to deal with insomnia cases in cases of obstructive sleep apnea. But someone has to know, because these medications are going to make difference related to the loop gain, related to the arousal threshold, and they may produce a better sleep. So CBTI was and remains the main therapy, cognitive behavioral therapy, the first we initiate in order to abolish insomnia in patients with COPD, in order to make patients use their medical devices, CPAP and BiPAPs more. And this is something we have to we have to try first. And all sleep labs should have a sleep psychologist. So I think we are sleep physicians, and all these things are complicated patients, complicated medications need sleep physicians who have the knowledge and the experience to do this. And first of all, remember what Hippocrates says, "Ophelein imi vlakin." Thank you.